Go ahead. Hello. Go ahead and introduce yourself. I'm James Nacciando, Jim. I work for GI Consultants here in Reno, and I'm happy to be taking part in this talk for ECHO Project. I am originally from Winnemucca and came back to Nevada after having attended medical school here in the 90s and then going to Oregon for 7 years. I came back in 2005, and I love practicing GI here. So thank you very much for signing on. Are we good to go? We will be here. So my topic today is a discussion of peptic ulcer disease and kind of an update on Helicobacter pylori treatment and management. I created this talk basically from a slide set that I used for a talk on upper GI bleeding for some internal medicine residents last summer. So I did it a little bit last minute, but I hope that you'll feel free to jump in and ask questions if you have something to add or if you have anything that you don't understand. So first off, a bit of background. Incidence of peptic ulcer disease and gastric cancer is actually on the decline in the United States, and that's probably attributable to eradication of H. pylori. At the same time, we're seeing increases in esophageal cancer, so this is kind of interesting from an epidemiological standpoint. We definitely are still trying to fully understand the relationship of Helicobacter pylori infection and esophageal disorders, reflux, as well as cancer. So one thing I would urge is that you don't necessarily check for H. pylori in patients who have classic acid reflux symptoms, as if you find the bacteria and eradicate it, their acid reflux might actually get worse. We think of it as kind of a protective factor. So basically a peptic ulcer is simply a defect in the GI mucosa that extends through the muscularis mucosa, the first of the two muscle layers in the 5-layer wall. Cost estimates suggest that about $5.65 billion per year in the US is spent caring for patients with peptic ulcer disease. The majority of that has to do with complications such as bleeding and possible gastric outlet obstruction from pyloric obstruction and surgeries that go along with that. So two major factors, as you probably know, are Helicobacter pylori infection, bacterial infection, and use of non-steroidal anti-inflammatory type medications, and we'll talk a lot more about that. The incidence is about 0.1% to 0.3% per patient year in the United States. It's higher in those with known active H. pylori infection. The incidence definitely increases with age. Risk of bleeding from a peptic ulcer is about 13-fold higher in persons over the age of 70 years compared to those under the age of 40 years. We used to think of peptic ulcer disease as predominantly a disease of males, especially up in the 50s and 60s and 70s. I know my dad talked about walking around with a pack of Maalox in his pocket all the time, and now we're seeing equalization in regard to gender, and it's probably attributable to the fact that we know about H. pylori, and we're eradicating H. pylori, as well as the fact that smoking rates in men and women sort of equalized over that same time frame, another risk factor for peptic ulcer disease. So etiology again, H. pylori and NSAIDs, the two major factors, although other infections are also possibly at play, such as herpes simplex, cytomegalovirus, Helicobacter pneumoniae, which is very similar to H. pylori. It's a little bit bigger bacterium in size, but it responds to the same treatments. TB, we don't see a lot of that here in this part of the world as far as peptic ulcer disease and whatnot, as well as syphilis can cause peptic ulcers. Drugs, NSAIDs, aspirin, the rest of the drugs I've listed here, really the risk goes up in conjunction with, or in combination with NSAID use. So steroids and NSAIDs are a really bad combination. so on and so forth. Hormonal factors. If we have a patient with a peptic ulcer and we feel confident that we've ruled out H. pylori and they're being honest with us about not using NSAIDs, and NSAIDs aren't sneaking in the picture somehow, then we really have to consider possibility of gastrinoma, the Zoller-Drellison syndrome, and might check a serum gastrin level. If you check that level and find that it is in the range of 500 to 1,000, that's kind of the gray zone. You want to take into account whether the patient's on a proton pump inhibitor, because it's very common to see a gastrin level around 500 to 1,000 in the setting of proton pump inhibitors. Doesn't necessarily mean the patient has a gastrinoma. Post-surgical contributions, we see a lot of patients who have had a Roux-en-Y gastric bypass coming in with what we call a marginal ulceration at the gastrojejunectomy site. Anytime the bowel is cut and anastomosed, the native blood supply is gone and they're at risk for some ischemic contribution to ulcer formation at that site. And that's exactly what we see quite frequently at these gastrojejunectomy sites. And then also patients who have known Crohn's disease, they can have Crohn's disease involving the upper GI tract as well. So anytime we do an upper endoscopy and find ulcers, we want to really be in tune to the possibility that it's a Crohn's ulcer and take some biopsies from the margins. This slide is just to underscore that we have some societal guidelines for both the peptic ulcer disease and upper GI bleeding, as well as recent updates regarding Helicobacter pylori. So, diagnosis of peptic ulcer disease, I really want to underscore that abdominal pain, so dyspepsia simply means upper abdominal discomfort of whatever etiology. Abdominal pain is not sensitive nor specific when you're thinking about peptic ulcer disease. So, a lot of times patients may say, well, I have pain, but it's better when I eat, or it's worse when I eat. And that could still be from a peptic ulcer. Basically, so kind of the textbook way to think about it is pain 2 to 5 hours after eating or in the middle of the night might suggest a duodenal ulcer, because then you're getting that postprandial sort of output of acid that comes a few hours later, making its way into the duodenum and irritating the mucosa or irritating the lining. Whereas the textbook answer for, well, I feel better after I eat, that might suggest a gastric ulcer. But you should keep peptic ulcer disease on the differential for any patient who's got upper abdominal discomfort. In regard to bleeding, so hematemesis, either bright red blood or coffee grounds, suggest bleeding proximal to the ligament of trite, so upper GI bleeding. The presence of frankly bloody emesis might suggest moderate to severe bleeding and ongoing bleeding. Coffee grounds might suggest more limited bleeding. And we'll talk a little bit more about potential roles for a nasogastric tube or lavage in this setting in a minute. 90% of melena does originate proximal to the ligament of Treitz, but you have to consider the possibility that it could be coming from a small bowel AVM or ulceration or neoplasm or even a right-sided colonic lesion. Hematochezia is almost always due to lower GI bleeding, but may occur with massive upper GI bleeding, such as I saw a couple of weeks ago in a patient who had a duodenal ulcer that had eroded into the gastroduodenal artery, and she literally, her life was saved by our interventional radiologist here at Renown. I had done an upper endoscopy and she was bleeding. It was just massive amounts, and I did inject a little bit of epinephrine just to try to sort of slow things, but it didn't really help much. So I had our interventional radiology colleagues take her down quickly and coil embolize, and they put like 5 coils in and literally saved her life from this massive duodenal hemorrhage. So, so we have abdominal pain, bleeding, and then penetration of an ulcer or perforation. So with penetration, we're thinking about lack of free perforation. So you might see a patient developing pancreatitis from penetration in the setting of a posterior gastric ulcer, or developing a contained abscess, which might be seen on imaging that you've ordered to evaluate for dyspepsia. With free perforation, the history might be that there's sudden onset, generalized severe pain, and on examination, you might actually see some worrisome findings such as darting sort of surgical findings. So about, as far as peptic ulcer disease and perforation, about 60% of those occur in the duodenum, whereas about 20% are in the antrum and 20% in the gastric body. With obstruction, we'll see this in the setting of patients who may have pyloric channel ulcers or duodenal ulcers, and they may complain of bloating, nausea, vomiting, early satiety, and we can sometimes treat this by, first of all, dealing with the inflammatory component, healing the ulceration, and then if there's underlying scar tissue, we can balloon dilate endoscopically. And if that doesn't work, then we'll have our surgical colleagues conduct, say, pyloroplasty or even gastrojejunectomy to bypass the obstruction. As far as labs, most patients, aside from the setting of an acute GI bleed, most patients with peptic ulcer disease will have a normal CBC. They might have some component of iron deficiency anemia. There's also an ulceration called a Cameron's ulceration or erosions, which occur in the setting of a large hiatal hernia, and these are along the rim of the hernia. They're sort of more ischemic in origin from a little bit of movement of the stomach up and down across that hernia, and that's a board question for us. They can lead to just small amounts of blood loss over time and iron deficiency anemia, as well as gastritis or other ulcerations that are not bleeding overtly. As far as contrast imaging, if you obtain an upper GI series, you could possibly demonstrate an ulcer. If it's a duodenal ulcer that the radiologist reads and it's benign appearing without any alarm clinical features such as early satiety, melena, or iron deficiency anemia, then there may not be a need for endoscopy. That would be a setting where you could go ahead and check for H pylori infection, take your history to see if there's any involvement by NSAIDs and deal with that appropriately. If the ulcer is gastric or if there are alarm findings, then we definitely would recommend an endoscopy. About 8 to 10% of gastric ulcers are malignant. That's a little bit older data, but we still, the guidelines suggest that patients with gastric ulcers should have a repeat look after treatment about 8 weeks later. So a referral for endoscopy would be appropriate at that point. So I'm not sure about your various roles as far as how involved you might be in dealing with an acute GI bleed, but a little bit of this talk does deal with management of the upper GI bleed. So as far as management of any patient presenting with an upper GI bleed, I just stress the importance of assessing hemodynamic stability and resuscitate, resuscitate, resuscitate. I frequently get the call early on from the emergency department about a patient, and there's a tone of kind of frantic chaos, and I just remind everyone to kind of focus on resuscitation first and get the patient appropriately triaged. Then we'll do our diagnostic studies such as upper endoscopy. One of the diagnostic studies that we do have available here in town is CT angiography. So that's nice. In patients who do not have renal insufficiency, we can use a CT scan to go ahead and look for the site of bleeding, and that helps us to decide whether the patient should have an urgent upper endoscopy versus start a rapid laxative preparation for possible colonoscopy as well. So after you've assessed the patient's hemodynamic stability, made sure that you have large bore IV access and ordered fluids and labs, you'll begin by taking a history and physical, obviously. The goal is to assess the severity of the bleeding, so you're going to possibly be looking for orthostasis, identify the potential source. Again, CT angiography is something we have available here, and then you're going to use your clinical acumen regarding taking the history. You know, does the patient describe melena versus hematochezia? Did they throw up blood, so on and so forth? Determine if other conditions are present that might affect management, such as known history of peptic ulcer disease. About 60% of patients presenting with an upper GI bleed who have a history of GI bleeding are bleeding from the same source. Does the patient have a history of cirrhosis? Keeping in mind that about 50% of the time, patients with cirrhosis are bleeding from non-variceal sources like peptic ulcers, and then start formulating a differential. So this was kind of an interesting study from Duke University. It was a retrospective analysis looking at predictors of upper GI source of bleeding. So I'd highlight that melena on exam showed a likelihood ratio of 25 that the patient was having an upper GI source versus lower source. Patients' report of melena also had a likelihood ratio of 5.1 to 5.9, but I think this just kind of shows that patients often don't really look or aren't able to describe, true black to purple bowel movements versus frank blood. So it underscores the importance of doing a digital rectal examination in the emergency department to help sort out what's going on. Some other factors, blood or coffee grounds via an NG lavage, likelihood ratio of 9.6, elevated BUN to creatinine ratio greater than 30, a likelihood ratio of 7.5. There were actually some studies in kids back, I think, in the 90s, showing that BUN to creatinine ratio greater than 30 had a sensitivity of like 70% and a specificity of 95% for an upper GI source of bleeding. So basically, blood is a good source of protein, and it's metabolized and releases urea. And then there's probably also some decreased renal perfusion in the setting of an acute GI bleed. So those two factors lead to that elevated BUN. Also, I didn't put it on the slide, but frank red clots per rectum has a likelihood ratio of 0.05, so again, suggests a lower GI bleed, obviously. Other factors to consider, as I mentioned, prior GI bleed, liver disease or cirrhosis, which might lead you to suspect varices or portal hypertensive gastropathy versus peptic ulcer disease. Renal disease, aortic stenosis, or a history of HHT might suggest angiodysplasia anywhere throughout the GI tract. NSAID use, tobacco, or a history of H. pylori would obviously suggest peptic ulcer. Tobacco, alcohol, or history of H. pylori could also raise the bar for a cancer, such as a malt lymphoma in the stomach or a gastric adenocarcinoma. These ischemic marginal ulcerations would be on your differential for anyone who has any sort of gastroenteric anastomosis. Again, especially the patients who have had bariatric procedures. Take a thorough medication history. So you're thinking about aspirin and NSAIDs either alone as risk factors or in combination with other medications. Again, especially those patients who are on steroids plus NSAIDs or steroids plus NSAIDs plus aspirin, they have quite an elevated risk of peptic ulcer disease development with the complications such as bleeding. Again, overall, for a patient presenting with upper GI bleed, especially if the patient's complaining of esophageal symptoms such as dysphagia or non-cardiac chest pain, you might consider pill esophagitis. So that's going to be like your bisphosphonates, potassium, NSAIDs, certain antibiotics. Remember to ask about bismuth, so Pepto-Bismol use, and iron in patients who are complaining of black stools, dark stools, changes in bowel movements with hard, dark stools, things like that, because we could be going down the wrong path thinking about a GI bleed in those patients who are utilizing those medications. Okay, so back to assessment of the patient. So hypovolemia, mild to moderate hypovolemia is suggested by resting tachycardia, heart rate above 95 to 100 beats per minute. Blood loss, volume loss of at least 15% might be suggested in the patient with orthostatic hypotension. Blood volume loss of at least 40% in the patient with supine hypotension. So this helps you to decide how to triage these patients and helps our ER docs to decide how to triage them. The patients in the third group are certainly going to be appropriate for ICU admission here in town. Depending upon where you all practice, they might be appropriate for transfer to a center where there is surgical gastroenterologist and or interventional radiologist support as well. On your exam, obviously, signs of an acute abdomen would lead to stat imaging to rule out perforation, looking for free air. So you're going to be getting a 3 view of the abdomen or a CT of the abdomen. Thinking about perforated peptic ulcer disease or ischemic gut. Okay, how about nasogastric lavage as a part of the workup? So the most recent guidelines, there are 2 guys, Lauren Lane and Dean Jensen, who are sort of the gurus of GI bleeds. One's from Yale and one's from UCLA, I believe. And the most recent guidelines with these 2 docs at the helm suggest that nasogastric lavage remains controversial. So when I was training, we were always chastised if we didn't do an NG lavage in the ER, but I'd have to say, in my anecdotal experience, if I ask patients what their worst memory was from a prolonged hospitalization, a lot of them are going to say having the nose hose, the tube put in to their nose. So unless it has a really good indication, why do it, right? So for instance, in this study, they looked at 632 patients admitted with GI bleeding, and those who had an NG lavage were matched with controls. And they found that NG tube lavage was associated with a shorter time to endoscopy, but no difference in meaningful clinical outcomes such as mortality, need for surgery, etc. So the guidelines still do not recommend NG lavage. There's potentially a role when it's unclear if the patient has ongoing bleeding and we're concerned about timing of interventions such as endoscopy or calling a surgeon or so on and so forth. There's also potentially a role in helping to remove particulate matter and fresh blood clots to help us in facilitating endoscopy and improving our visualization, increasing the chances that we'll see the source of bleeding. Red blood or coffee grounds per NG does confirm an upper GI source and predicts whether the bleeding is caused by a lesion at increased risk for ongoing bleeding. But the problem is that the lavage could be negative if the bleeding has stopped or if it's arising from a source distal to the pylorus. And if we're going to do an NG lavage, we want to ideally, before we say it's negative, we want to pull back some bile back through the NG tube, showing that we've actually sort of lavaged thoroughly. So personally, I would suggest only lavage if there's concern about particulate matter, fresh blood, or clots that need to be removed. And, you know, these days we're actually using prokinetics pre-endoscopy to help clear the stomach and improve our visualization. So we might use a dose of erythromycin and or Reglan. So the role is really decreased. So again, really important in the assessment of the acute GI bleed to conduct that rectal exam. I know it's a lot of times it's easy to skip that. And, oh, how's it really going to change things? But patients are not that great at describing melena versus hematochezia, so it's helpful to know so that we know whether to do an urgent EGD, and then if that's negative, rapidly prep the patient for a colonoscopy versus just going straight to the rapid prep. Labs, so obviously you're going to get CBC, CMP, and coagulation parameters in the initial evaluation of a patient presenting with GI bleed. Cardiac enzymes in an EKG for older patients is recommended. If initial labs show a low MCV, then I always recommend ordering iron studies prior to transfusing so that we can figure out kind of the chronicity of the problem. Again, elevated BU to creatinine ratio may be helpful, and keeping in mind that the initial hemoglobin may be normal. The patient is losing whole blood, so it might even take up to 24 hours for that reequilibration where we see a drop in hemoglobin in the setting of an acute GI bleed. We talked a little bit about triage in these patients. So the Rockall criteria is kind of a nice, simple scoring system to help decide who can go home from the ER after presenting with a peptic ulcer. So a score less than 2 is associated with an extremely low risk of further bleeding, like less than 1%. And so those patients, per guidelines, could be discharged to home safely from the ER. So that could be even someone like as old as 75, 76, who doesn't have other comorbid conditions, who's found to have like a clean-based ulceration, or a Mallory-Weiss tear. Let's see here. There are some other scoring criteria to help decide who could go home from the ER versus being admitted to the hospital after presenting as well, but they're a little bit more complex. So I like the Rockall criteria, and that's the one that we're using. Now, in reality, it's super rare for us to send someone home. Even when we scope them in the ER and find a clean-based ulcer, they've usually already been seen by our doctors, like our hospitalists or family practice docs, and like the admission is already underway. The orders are written and everything, so they usually get admitted, at least for an observation study overnight. But occasionally we do get to them first, get them scoped, and say, hey, this patient could really go home. So just general support, pre-endoscopy, obviously the patient's going to be NPO. You want to try to make sure there are 2 large caliber peripheral IVs. If the patient's orthostatic or having supine hypotension, then it's a good idea to get central access. And again, depending where you're practicing, you might be arranging for transfer at that point as well. Patients who are having large volume hematemesis or whatnot, or who are potentially cirrhotic, may even need to be intubated so that they can have a protected airway at the time of an endoscopy. So let's talk about blood transfusions a little bit. So there's been a push at our major hospitals here in Reno to go to a more restrictive transfusion protocol, meaning if a patient has a hemoglobin above 7, then hold off on transfusing. And that's based on data that shows that patients who are transfused more aggressively might have worse outcomes, and particularly patients with variceal hemorrhage, but it's really across the boards. An exception to this would be the patient with unstable angina, where the goal of maintaining a hemoglobin greater than 9 should be followed. And what I typically do is in patients who are I'm seeing in the hospital with active GI bleeding, whether it's upper or lower, or sort of more occult bleeding that's not overt, I will talk to the cardiologists and have their input as well before saying, oh, look, this patient doesn't have a hemoglobin less than 7, so don't transfuse them yet. But if it's someone who doesn't have unstable angina or cardiac history, then it's not only safe but preferred from a standpoint of even mortality outcome to hold off on transfusion. So this next slide just shows there were 2 studies, one retrospective and one prospective randomized study that again advocate for a more restrictive versus what they call liberal transfusion protocol. So the second study, I'm sorry, I forgot to put my references on here on the slide. The second study, the one thing I would say about the study is that all the patients were scoped within 5 hours, which that's pretty aggressive. We frequently do scope before 5 hours, but a lot of times, we consider urgent endoscopy to be within 24 hours. So it could be that their data was affected a little bit by the fact that they were so aggressive about getting people scoped early on. But nonetheless, they showed a mortality benefit that was statistically significant at 5% versus 9% for those patients who were transfused at a lower threshold of 7 grams per deciliter versus 9. So at Renown in Reno, we have a blood protocol group that's multidisciplinary that has trauma surgeons, gastroenterologists, hospitalists, pharmacists, nurses, etc. involved. And we've really been tracking our transfusion requirements and educating, and we'll probably look at outcomes data later. In regard to platelets, we like the platelet count to be over 50,000 prior to doing any endoscopy, ideally. Fresh frozen plasma might be transfused in patients with an INR. We now, when I made this slide, the threshold was kind of an INR below 1.5, but we now know that it's safe to do urgent endoscopy as long as the INR, oh, actually I did talk about it on this slide here, as long as the INR is less than 3. These guys did a study showing that if high-risk stigmata such as active bleeding or a visible vessel within an ulcer bed was found, endoscopic therapy could be applied, and then later continue transfusing FFP to a goal INR less than 1.5, and the outcomes were the same as in those patients who didn't get an endoscopy until their INR was less than 1.5. So we shouldn't necessarily be waiting on transfusions of fresh frozen plasma to conduct endoscopy. As far as acid suppression, we often use proton pump inhibitor drip therapy, which I would just underscore that it has not been shown that a proton pump inhibitor drip improves important clinical outcomes such as morbidity and mortality. What we do know is that it decreases the need for repeat endoscopy and the need for endoscopic therapy during endoscopy, such as heater probe therapy, hemoclip placement, and things like that. So we really got kind of focused in the management of these patients in the hospital on early administration of a bolus followed by a drip. But we're getting new data that suggests that IV bolus dosing, like pantoprazole 40 milligrams IV twice a day, may be just as effective as that drip and much less costly. So that's kind of to come. So as far as stigmata of risk of rebleeding within peptic ulcers, so these are findings at the time of endoscopy. An active spurting vessel has a 55% chance of a rebleed within 72 hours. And this is considering that we've actually applied therapy such as hemoclip placement, injection of epinephrine, or heater probe placement. Epinephrine alone is not a good therapy. It might stop a bleed temporarily, but there's a super high risk of rebleeding, so we don't advocate for using epinephrine alone, and instead we use it in combination with either hemoclip placement or application of cautery. So in patients who get scoped and we find, say, an active spurting vessel and then treat it, there's still a 55% risk of rebleed within 72 hours. If there's a visible vessel within the base that's not bleeding, there's a 43% chance. If there's an adherent clot, which is then removed and we treat the underlying source, there's still a 22% chance of rebleeding, and so on and so forth. So this helps us to kind of decide who should have IV PPI therapy for 72 hours, because what we're doing with the IV PPI is stabilizing clot formation over the base of the ulcer, and therefore hopefully decreasing the need for repeat endoscopic therapy and decreasing the chance of recurrent bleeding. So those who have active bleeding, a visible vessel, or an adherent clot, we try to keep them in the hospital and continue the drip for about 72 hours. So in deciding how to manage anticoagulant or antiplatelet therapy in the setting of upper GI bleeding, we have to consider bleeding risk versus the indication for the antiplatelet therapy, or in other words, the thrombotic risk. So in the setting of a patient who comes in on Coumadin, we do want to reverse down to, like I mentioned, a goal INR between 1.5 and 2.5. So we'll typically use fresh frozen plasma, which is faster in onset than vitamin K. And when we've used vitamin K, there's that difficulty in reinstituting Coumadin that can occur. Patients who are on the direct oral anticoagulants, in other words, the Pradaxa, Xarelto, and Eliquis, if they're bleeding and they're unstable and we're unable to get control of things, then we'll often have the pharmacist help with reversal of those agents. It's quite costly, but they can be reversed. Here at Renown, we're using TEG, which is thromboelastography, and essentially what TEG tells us is what part of the clotting cascade is problematic, because we're focused on using the INR and the platelet count historically, but that doesn't tell the whole picture. Like some of these patients, for instance, the cirrhotic who comes in with an elevated INR may actually be hypercoagulable. And so TEG gives us an idea of whether patients need cryoprecipitate or whether they need platelet transfusion versus FFP. And I think it's been used a lot in the trauma setting and cardiothoracic surgery, and it's going to increase in utilization throughout the hospitals, probably in the States. It'll help decrease inappropriate use of blood products, I think, and target correction of the appropriate part of the clotting cascade. Okay, so after a bleed and a patient's had endoscopic therapy, treatment of their peptic ulcer disease, when can they resume their prior anticoagulation? The current guidelines from both GI and cardiology societies would suggest resuming aspirin immediately post hemostasis if it's secondary prophylaxis, so patient who has cardiac disease, for instance. Coumadin, we try to hold for about 72 hours, but then resume it. And I think we used to kind of fly by the seat of our pants and say, oh, a week, or, oh, you know, I've seen, when I was training in Oregon 10 years ago, sometimes we'd say, well, a month. And, you know, we really don't need to do that. I think 72 hours is plenty. It's less clear for the new DOACs, again, the Eliquis and Pradaxa and Xarelto. So that data is to come. But and then if bridging is indicated for patients who are super high risk, a recent thrombotic event, pulmonary embolism or whatnot, then we recommend weight-based heparin drip initially so that we can hold it and quickly reverse it if needed, if they have evidence of recurrent bleeding. Okay, so non-steroidals and ulcers. If the patient, okay, so first of all patients who have a peptic ulcer should be checked for H. pylori. And I'll talk a little bit about the tests in a moment, but none of them are perfect. So if you don't believe it, then get a second test and continue until you're happy that this patient does not have H. pylori. It's that important. If the patient is H. pylori positive, after H. pylori is treated and we've verified that the H. pylori is gone, then it's okay to resume non-steroidals. If the patient with the peptic ulcer is H. pylori negative and we're confident that they really are negative, then we try not to resume NSAIDs. But you know, NSAIDs are, patients love NSAIDs. They help. I mean, I love my Advil. So if they must resume the NSAIDs, then we prefer a COX-2 selective. Even in the setting of a COX-2 selective, I would recommend concomitant therapy with either a histamine blocker or a PPI to prevent risk of recurrent peptic ulcer development. If they're going to use a non-selective NSAID, then I would suggest a PPI rather than a histamine receptor blocker. And as you know, I mean, this is becoming more controversial because there was media attention in the last couple of years to potential relationships between PPIs and anything bad. It seems like renal insufficiency, dementia, stroke risk. So I spend a great deal of my time these days having discussions with patients about their PPIs and these potential risks. And so right now I just try to educate patients on kind of the difference between secondary outcomes in studies and good quality primary outcome study design, and letting them know that the bottom line is, you know, if there's a strong indication for a PPI, like healing of a peptic ulcer or true GERD or history of Barrett's esophagus with intestinal metaplasia in the esophagus, then my opinion at this point is that the potential gains from a PPI outweigh the risks. And we need good study designs to be able to say there's a causative relationship between PPIs and dementia or renal insufficiency, for instance. Okay, so that was an aside. Some folks in Europe recently did a retrospective analysis utilizing 7 population databases from Northern Europe to look at combinations of medications and risk of upper GI bleed from peptic ulcer disease. So essentially, as I hinted at earlier, they found that the highest risk is seen when non-selective NSAIDs were combined with steroids. And if a COX-2 inhibitor was used, the risk still existed, but it was definitely attenuated from a relative risk of almost 13 down to 6. Yeah, so the pearl is just NSAIDs for the shortest duration possible and at the lowest doses is the way to go. Okay, moving on to Helicobacter pylori. So in general, Helicobacter pylori was identified in the 80s as a source of problems when 2 guys in Australia basically infected themselves and then scoped each other and sort of documented that this bacteria is responsible for this inflammatory problem in the stomach. So acute infection leads to this sort of antral gastritis, and that's when we see the highest risk for duodenal ulcers to occur because the body of the stomach, where most of the acid is produced, hasn't been affected yet. Chronic infection, what happens is the infection sort of propagates and migrates up the stomach, if you will, and leads to more of an achlorhydria, and that's where the risk of gastric ulcer is sort of higher than duodenal ulcer per se. And that's also where we see this sort of decreased acidity overall, and where it may actually be protective in patients like me who have, you know, bad reflux. Okay, so what we're seeing lately is that new challenges exist in eradication of H. pylori. So the bacteria was identified. We identified the relationship to GI problems, not only gastritis and peptic ulcer, but also malt lymphoma and gastric adenocarcinoma as well. The World Health Organization said, hey, yeah, this is a class 1 carcinogen. So that means whenever we identify it, we need to get rid of it. And this led to a push towards eradication, especially in parts of the world where gastric cancer is seen the higher incidence, like Japan. So in the United States, since we in the 80s and 90s started to really look for H. pylori infection and get rid of it, we've seen a decrease in gastric cancer. But what we're now seeing is that immigrants from other parts of the world are having a much higher chance of having active infection. So it's sort of being imported, if you will. So we have to be very mindful of the fact that, yeah, we used to talk about H. pylori a lot, and then at our GI conferences, at least, it sort of fell off the radar as something of interest. Now it's coming back because about 80% of immigrants, for instance, from Central and South America are infected. So we're seeing a kind of a resurgence. And at the same time, we're seeing increasing problems with resistance to certain antibiotics, which we're going to talk more about. So I talked a little bit about this increased prevalence among minority groups. So for instance, reservations or African Americans and Latinos, higher prevalence. I also talked a little bit about the fact that we have recent updated guidelines in management of H. pylori that sort of focus on needing to tailor therapy. The goal should be a 95% cure rate, and a lot of our current therapies, which are utilizing clarithromycin, are not meeting that goal. Let's see, so yeah, so it's just, I wanted to underscore the importance. After the relationship between H. pylori and a peptic ulcer has been established, it's very important to verify eradication. I'll talk about the tests in a minute. Oh, and then also, once you verify eradication, try not to just leave the patient on a proton pump inhibitor. We see that a lot. I think patients leave the hospital after a peptic ulcer on proton pump inhibitor therapy, and they're sort of like, you know, left on it for all of eternity is how people look at it. They don't necessarily have a good indication for long-term PPI therapy.
Get about 5 minutes before you.
Okay, so regarding test and treat strategy, this simply refers to dealing with those patients with uninvestigated dyspepsia. It is a cost-effective strategy as long as there are no alarm features present, again, such as melena, iron deficiency, early satiety, weight loss, to go ahead and test the patient for H. pylori, and if positive, then go ahead and treat it. If symptoms don't resolve, then you want to verify that you've eradicated the infection, and then consider whether the patient may need endoscopy or, you know, a full gastroenterologist evaluation. Recent guidelines regarding H. pylori also suggest that we as gastroenterologists should be taking gastric biopsies in patients who are undergoing a scope for dyspepsia, even when the lining looks normal. And that's a change for us. We used to say, oh, H. pylori is not doing anything bad here as long as the lining looks normal. I can definitely say, oh, this is functional dyspepsia or something else, biliary disease or something. But we now know that even in the setting of low-grade inflammation, patients can have symptoms, and we may not see that. So we're trying to biopsy, and we're also trying to take biopsies from the antrum and the body of the stomach to increase our sensitivity. There's also recommendation in the new guidelines to consider testing, and if positive, treating for H. pylori before we start therapy with low-dose aspirin. So that's a whole lot of patients. And also to consider testing and treating prior to starting chronic NSAIDs therapy. Again, a lot of people. Let's see, and in patients with iron deficiency anemia, we know that testing, and if positive, eradicating H. pylori infection will make it easier to replete the iron with oral therapy. It will increase the absorption of the iron. Also, interestingly, ITP, patients with idiopathic thrombocytopenic purpura, there's a relationship that we don't fully understand between H. pylori and ITP, and the oncologists are actually testing those with ITP to see if they have H. pylori, and then if positive, treating it, and it raises the platelet count. So it's interesting, we're discovering this relationship between H. pylori and health entities beyond the stomach or the duodenum per se. So as far as diagnostic tests, we can do mucosal biopsy for histology, so that's something I would do. We can do rapid urease testing on those biopsies right there in the endoscopy lab. Serologies, of course, urea breath tests, fecal antigen tests. The urea breath test and the fecal antigen test are the two non-invasive tests for active infection, in contrast to a serology, which doesn't necessarily tell us there's active infection, right? Because we're just looking for antibody. After treatment, the serology can stay positive for up to even 18 to 24 months, so it's not a good test to verify eradication. The urea breath test and fecal antigen test both have high sensitivity and specificity, and I have a table I'll show you in a minute. But those are affected by proton pump inhibitor therapy and antibiotics. Just keep that in mind. So the one place where there's still a role for serology is in the setting of acute upper GI bleed. Blood in the stomach greatly reduces the sensitivity of all of the other tests. So I like to have the option when a patient comes in, I scope them, I find an ulcer, of ordering a serology. The problem is that the hospitals are getting rid of serology because it's costly and we have all these other tests. So that makes it a little bit challenging for us to make sure that that patient has been tested for H. pylori prior to being discharged from the hospital. And I would say that's one place that primary care can really be of great help too, is just when that patient comes back to see you in the clinic, don't assume that they were tested for H. pylori or that test result was back by the time the patient was discharged. That's a place where you can really help to close the loop too and make sure that they got the test, the result was back. If it was positive for H. pylori, the treatment was started. So this table just shows the sensitivity and specificity of the various tests. We're actually conducting the urea breath test in our clinic. Again, after a patient has, so first of all, if a patient's on proton pump inhibitors or histamine blockers, they have to hold them for at least 2 weeks to avoid a decreased sensitivity. If they're on antibiotics, they have to wait for a month to avoid decreasing the sensitivity of the tests. We don't really use culture. As far as treatment guidelines, so triple therapy, that's PrevPAC, so that's clarithromycin, amoxicillin, and PPI therapy. It's still recommended, but with some clarification. We're trying to move away from using clarithromycin because there's a lot of resistance. And what happens is the bacteria mutates. These genetic mutations lead to decreased binding of the antibiotic, and they decrease the effectiveness of the triple therapy from high 70 to 90% down to about 30%. And there's definitely a link between prior macrolide exposure. In fact, it's almost linear. So the chance that a patient's going to have decreased effectiveness due to resistance from PrevPAC or triple therapy goes up in a linear fashion, and depending on how many times the patient's had macrolides for sore throats or whatever indication outside of the gut. So it's a good idea to ask about prior macrolide therapy. Another thing we could do is we can test for resistance, but that requires obtaining a specimen and then culturing the specimen, which right now is not commonly done. So what we're moving towards is using more quadruple therapy. So that's bismuth plus tetracycline plus flagyl, metronidazole, and a PPI. And that's Pylori is the trade name for that one. And I don't have any link to any of these companies. So, so this is a good choice really for any patient, but certainly for a patient with macrolide exposures in the past, because it still has a pretty high effectiveness. We're also sometimes recommending concomitant therapy or sequential therapy. And so this is going to be quadruple therapy plus clarithromycin, or 5 days of the clarithromycin-based therapy up front, and then 5 days of the quadruple therapy at the end of the regimen, which has been shown in some European studies to have very high rates of eradication. So I prefer to hold off on concomitant therapy or sequential therapy for those patients who have failed either triple therapy and or standard quadruple therapy. This just talks a little bit about when to use quadruple therapy. Additionally, some of the therapeutic regimens use levofloxacin, but just like clarithromycin, we're seeing some genetic mutations leading to resistance to levofloxacin-based therapies as well. There are some mutations which can lead to metronidazole resistance, but what we find is that at the doses of metronidazole that we use, it overcomes that resistance. So the takeaway is that we're moving away from a one-size-fits-all approach to therapy for H. pylori, and because we're seeing such increases in clarithromycin resistance and levofloxacin resistance. So we're almost done. Pearls. So I would say, in the management of any upper GI bleed, assess hemodynamic stability first. We should take our own pulses and begin resuscitation. Focus on resuscitation, IV fluids, 2 large bore IVs, and correcting coagulopathy. My colleagues told, when I asked them, when I told them I was going to give this talk, they said, really stress the fact that almost every patient with an upper GI bleed should be receiving fluids by the time we see them in the ER. And then don't forget to do a rectal exam because your impression of what constitutes melena is probably more accurate than the patient's, and that has a really good likelihood ratio of predicting upper GI source versus lower and helping to triage them towards that effective therapy that could potentially be life-saving. Utilize the BU into creatinine ratio. Greater than 30 has a really good sensitivity and specificity for an upper GI source. Pantoprazole drips, proton pump inhibitor drips, don't affect clinical outcomes as much as just decreasing the chance of need for repeat endoscopy during the hospitalization. Know your transfusion parameters, and I would urge you to focus on a hemoglobin of 7, and rather than a low threshold to transfuse, be willing to check that patient's hemoglobin every 6 hours for the first 24 hours or the first 48 hours, and then transfuse if needed. Because you're not only potentially saving that valuable resource, blood, but also affecting meaningful clinical outcomes, including mortality, by not over-transfusing. Attention to H. pylori and NSAIDs in any patient who has a peptic ulcer. Really make sure that you've checked for H. pylori and that you believe the test result. In other words, was it affected by proton pump inhibitor use, blood in the stomach at the time that the test was obtained, et cetera, et cetera. And remember that patients often don't realize that they're taking NSAIDs because they may not know the names of all the NSAIDs. So really a thorough search for NSAID exposure. If you don't find any link to H. pylori or NSAIDs, then think about checking a gastrin level. Remember that peptic ulcers are commonly asymptomatic, but peptic ulcer disease should also be on the differential for any patient with dyspepsia. So abdominal pain is not a great symptom as far as sensitivity and specificity for peptic ulcer disease. But keep peptic ulcer disease on that differential diagnosis. Complications could be heralded by new symptoms such as worsening pain, generalized pain might indicate perforation, weight loss or bloating might indicate gastric outlet obstruction from pyloric ulcer or duodenal ulcer. Remember, all patients diagnosed with peptic ulcer should undergo H. pylori testing, and we should tailor our therapies for H. pylori based on patient history of antibiotics. And that's all I have. Thank you. Are there any questions?
We got one. Okay, go ahead, Patricia.
I came in late. I'm so disappointed. I was looking forward to this. But my question is, for the stool test for H. pylori, is that also by PPI?
Yes, it is. Actually, the stool test, any of the active tests, so the stool test and the urea breath test, for instance, are affected by PPI use, histamine receptor blocker use, and antibiotics. So, keeping in mind that I will sometimes go ahead and obtain these tests, even though I know that the patient has not been off of their PPI, for instance, for a month, because some patients are just like, I cannot do, I can't go without my PPI, I have such bad reflux. So I tell the patient, okay, we're going to do this test. If the test is positive, it's completely believable, obviously. If it's negative, then we have to revisit whether we really need to try and get you off of the PPI for a month and do the test.
Okay.
Any other questions? Feel free to ask anything that has to do with GI or liver as well, since you have me here for a little bit. I'll try.
If nobody else has any questions, I'd like.
I think you can monitor it for now. You described kind of mild to moderate elevation of the enzymes. The ratio is interesting. So the AST about half the ALT. So that kind of helps me in thinking about etiologies. This is much less likely to have, say, alcohol, as a contribution, where we might think of the AST twice the ALT. What we often see is that, so we're seeing non-alcohol related fatty liver disease in the whole spectrum of NAFLD, as I call it, at epidemic proportions in our country. You all know that. We're rapidly approaching the point where fatty liver, non-alcohol fatty liver, is going to become the most common indication for transplantation in our country, overtaking Hep C or Hep C plus alcohol. So it's of paramount importance. And we harp on, the best thing patients can do to treat non-alcohol related fatty liver disease is weight loss. But here what we're seeing, I believe, in your patient is that the rapid weight loss has actually worsened the degree of inflammation, and I suspect it's going to level out and improve. But she's liberated so much triglyceride that's now getting put into her liver that she's likely seeing inflammation related to her rapid weight loss. Obviously, I want you to, and you may have already done all these things, but take a look at her medication list and see if there are any medications that may be contributing, like statins. And I don't get alarmed in the setting of fatty liver and statin therapy. I don't get alarmed to the point that I want the statin stopped until the aminotransferases, the AST and ALT, are like 3 times the upper limit of normal, okay? Because it's super rare for statins to actually cause clinically meaningful problems in the liver, even though they often cause this low-grade aminotransferase elevation and we freak out about it. The potential benefit is greater than any problem with a low-grade smoldering hepatitis. So what you might do if you haven't already done it is just rule out some other things, such as autoimmune liver disease by checking an ANA and potentially an anti-actin antibody, or previously known as anti-smooth muscle antibody, and take a full family history, any family history of iron metabolism disorders, maybe check a ferritin on this patient. If the ferritin is really high, over say 750 to 1,000, then we might need to check a gene mutation analysis, the HFE mutation analysis, to help rule out genetic hemochromatosis, okay? And then, your alpha-1 antitrypsin level, and then the viral hepatitis serologies. Also keep in mind that patients with celiac that's undiagnosed can sometimes present with a little bit of a hepatitis and thyroid abnormalities. So that's sort of my basics for the initial lab workup for a chronic hepatitis. But this is probably non-alcohol related fatty liver disease that's kind of spiked up a little bit because of rapid weight loss and and triglyceride being liberalized into her bloodstream and then taken up by the liver. Monitor it and call me if it's getting worse.
Thank you so much.
You bet. Also, I would say, we're still hoping that we're going to have some pharmaceutical or medication advice regarding our patients with fatty liver disease in the future, but so many studies have been done and really haven't panned out. The one place where there's a little bit of soft data is with vitamin E. The problem is that the doses in the studies for fatty liver were 800 units, and we know that there's the potential for negative cardiac effects at those high doses. So I sometimes put my fatty liver patients on 400 of vitamin E a day, along with that gradual sustained weight loss, and definitely with attention to their lipids and any diabetes. I think that's all the time we have. Thank you for signing on, everyone. Have a great day.
Thanks, everyone. We have behavioral health tomorrow.